Greetings. Thank you for joining us in today's webinar addressing difficulties with swallowing and activities of daily living in Parkinson's disease. We're delighted to have you in attendance today. My name is Laura Gousset and I will be moderating today's session and presenting with my colleagues Heather Hodges and Erica Vitek. I'm an LSVT Big instructor, and Erica is an LSVT Big instructor as well. And Heather is an LSVT Loud instructor. They will be introducing themselves shortly. But before we get started with today's presentation, we would like to acknowledge our funding support, which has helped make LSVT Big and LSVT Loud possible and what it is today. We've had funding support over the years from the National Institutes of Health, the Michael J. Fox Foundation, the Parkinson's Alliance, and the Davis Phinney Foundation. So next, I'd like to briefly go over the plan for the webinar so you know what to expect today. First of all, I'll cover some logistics. I'll then turn it over to Heather to cover a general overview of LSVT Loud and the LSVT Big programs, in addition to Erica discussing the LSVT program in more detail. Heather is further going to discuss changes in swallowing associated with Parkinson's disease, and then she'll be turning it over to Erica, who will discuss difficulties with ADLs associated with Parkinson's disease as well. Finally, at the end of the session, we'll have a little bit of time to address your questions. So in terms of logistics, right now everyone in the audience is automatically muted so that there's no background noise from the various environments where you might be joining us. But there are a few ways to ask your questions during the webinars, including the question and answer portion at the end. The first way is that you can type in your question. You'll see on the right side of your screen there's a control panel with a question box. When I see a question, I'll read your question aloud to the group and one of the presenters can respond. The second way is by raising your hand. You can raise your hand by clicking on the hand icon on that same control panel. When I see that you have a question, I'll unmute your microphone, call out your first and last name to let you know that your microphone has been unmuted, and then you can ask your question aloud to the group and one of the presenters will respond. The third way you can ask a question is simply to email us. If we run out of time for questions today, or if you think of a question after the webinar, you can email us at any time. I'll display this email address at the end of the presentation, but if you'd like to have it now, it is info, as in information, at lsvtglobal.com. So now I'd like to provide some additional information on our presenters today, Heather Hodges and Erica Vitek, and I'm going to turn the mic over to them, first to Heather, so that they can give you a little bit of an introduction and background on themselves.
Well, good evening, everyone, and I greet you tonight from Denver, Colorado. I am a speech-language pathologist and received my degree from the University of Colorado, which is where I began working on Dr. Lorraine Ramig's research team investigating LSVT Loud as a graduate student. I was the research coordinator for the last big study that we were involved with the NIH. And in addition to studying neurogenic voice, I also work for National Jewish Health in Denver, treating swallowing disorders, voice disorders, and other disorders in the adult and pediatric populations. I'm also fortunate enough to be able to be an LSVT Loud expert clinician and trainer for the workshops where we go and train other speech-language pathologists and certify them in this special therapy. So that's a little background on me, and I'll hand it over to Erica now, and she can introduce herself.
Good evening, everyone. I'm Erica Vitek, and I'm coming to you from Milwaukee, Wisconsin. And a little bit about myself, I have graduated from Concordia University, Wisconsin, and work as a full-time practicing clinician in the Milwaukee area with Aurora Sinai Medical Center. We have a regional Parkinson center at our facility, and I work in the outpatient rehab department. My primary caseload of patients is working with people that have Parkinson's disease and other movement disorders, as well as I work with patients that have problems with bowel and bladder function, which correlates really well with a lot of my Parkinson's patients who experience those difficulties as well. So I'm able to work with them on pelvic muscle retraining in order to help them with bowel and bladder issues. And so I'm very excited to be a part of the webinar tonight to share with you some more information about LSVT Big and how wonderful it can be for your patients, or if you are a community member joining us or you know someone with Parkinson's, excited to share that information with you tonight.
Thank you, Heather and Erica, and we really are lucky to have them presenting tonight. Both Heather and Erica are truly experts in the field of Parkinson's and specifically in the delivery of LSVT Loud and LSVT Big. Each of them collectively has seen hundreds of patients with LSVT Loud and LSVT Big, and so I think this will be a really great webinar tonight and hopefully informational for you. So we do disclose to you that the three of us actually, Heather and Erica and myself, do receive lecture honorarium and travel reimbursement from LSVT Global, and furthermore I'm an employee of LSVT Global as well. The objectives of tonight's presentation are to briefly explain the motivation behind LSVT Loud and LSVT Big programs. Secondly, to discuss the difficulties with swallowing associated with Parkinson's disease, and also to discuss common treatment approaches. And thirdly, we want to describe how LSVT Big can address difficulties with activities of daily living associated with Parkinson's disease. So I am going to now turn it over to Heather, who is going to introduce this topic of ADLs and swallowing issues in Parkinson's disease.
Thanks so much, Laura. So as therapists, we absolutely see that activities of daily living, speech, and swallowing difficulties are common in those with Parkinson's disease and pose significant issues. Some of the difficulties they can pose will affect a person's quality of life, certainly their independence, and their safety. When you can't be heard or understood by others easily, or when you have difficulty with mobility, these can translate into significant safety issues. We also see that these difficulties can affect one's ability to work or to take care of family members, such as younger children or perhaps other spouses. The ability to live alone. When activities of daily living are impacted, that especially can affect someone's ability to live independently. And overall, we see just this ability to participate in life really becomes affected. Not being easily understood, people start to withdraw from social situations. Difficulty getting around or with dressing, people may start to retract from social situations and stay in and opt to stay home or to not be able to go out as they would have normally. So we really see that these can have an impact across a person's life and their involvement, the degree of involvement in their life. Next slide, please. And so with this, people with Parkinson's disease often require therapy from an occupational therapist, physical therapist, speech therapist to address these issues. And so the question arises, what options do they have when they go to therapy? Next slide. The traditional therapy approach was piecemeal, where if somebody came into a speech therapy office, for example, and they didn't have good breath support to be able to project their voice, they would first begin with respiratory retraining. And then once that was established, they would try to work on vocal quality if the person was hoarse. If someone had a swallowing issue, that would then be addressed later in another therapy. So it was a piecemeal approach not only in speech pathology, but also in the occupational and physical therapies that patients were receiving well. And the intensity of therapy tended to be pretty low, meaning that patients would come once a week for multiple weeks at a time, but they were only being seen once or twice a week. And so the treatment also would just address the physical components. You know, if you needed to learn to take bigger steps, it would be focused in on that. If you were too quiet, it was about how to get you louder. But we saw that there was no addressing the sensory impairments that come with Parkinson's disease. These impairments that we see where patients don't think that they're quiet when in fact their voice is quite low and hard to understand. Or patients felt like they were walking and taking normal-sized steps when in fact it was a shuffle. So any progress that patients would make in their therapy rooms wouldn't walk out the door because the sensory part was not addressed. And if patients felt like they were shouting at people or that they were taking big exaggerated movements that were awkward and strange looking, they weren't motivated to do it outside of with their therapist. And so that translated into very little expectation for lasting improvement with these patients. Other traditional therapy approaches were very compensatory focused. So using, for example, an amplification system, a microphone with a speaker for those with Parkinson's disease, or using ADL adaptive equipment such as a walker or cane, to name just a couple. So they really weren't effective, these traditional approaches, into making a positive impact into the activities of daily living or on the speech and swallowing impacts that Parkinson's patients were having. Next slide, please. With these more traditional therapies, the suggested compensatory strategies were to tell patients avoid multitasking when you're doing other daily activities. Use external cues, so putting perhaps tape marks on the carpet showing what would be a normal size step to take, or putting up signs to talk louder. And so it was very externally cued rather than the patient feeling what they needed to do and cueing them from themselves, reminding themselves internally that they needed to talk loudly from the inside. They weren't actually speaking loud, I should clarify that, but it felt loud, and that they should take bigger steps that were in fact totally normal steps, but to them they had to cue themselves from the inside that they were taking larger movements. So these external cues, like the marks on the carpet or signs reminding them to speak in a different way, were some of the compensatory strategies, and not necessarily very realistic. Another strategy that would be suggested was to take complex movements into a series of simpler components of the overall task and to learn to execute it sequentially. So an example of that from the speech realm would be take a big breath, open your mouth, speak loudly, over-articulate. And so just that alone, that's 5 different steps that the patient would have to learn individually and then try to integrate all together. So it made speaking very laborious. And so that's where these compensatory strategies didn't always work. And some more details on that are actually on our next slide, which we can advance to now, as to why these strategies didn't necessarily work. We recognize that life requires multitasking. There are lots of distractions left and right, and so telling patients to walk or to talk in situations where they weren't distracted or otherwise engaged is not very realistic. The external cues, you can't walk out the door and have marks on the carpet everywhere that you head as to how to take an appropriately sized step, or taking around a sign that said, speak loudly. That's not something very realistic. And with the adaptive devices, like the microphone with the speaker, that's not very realistic to take into all situations. To public places, if you're going to a restaurant, it's probably not something you would set up at your table, for example. And also, it's hard to remember one procedure that you're changing when you're changing something about movement or about a behavior that you have. It's hard enough to remember one part, let alone dozens. If I expected a speech patient of mine to remember, take a deep breath, open your mouth, have a clear voice, over-articulate, that's a lot for them to do. However, telling them one thing, such as speak loud or think loud, talk to me, say good morning in a loud voice, naturally they would take a deep breath, open their mouth, and have a better vocal quality when all I had to tell them to do was one thing, one procedure, versus this sequence of events that they were otherwise forced to try to execute. Next slide, please. So LSVT Big and Loud are both evidence-based protocols. These protocols attack the underlying mechanism, which we certainly see with our early Parkinson's patients. It can be compensatory as well with our moderate to later stage Parkinson's patients. And so we see that we are trying to develop alternative circuits within what the patient is doing, or add in adaptive aids such as a cane or a walker when needed, but we are also attacking their underlying mechanism, the slow movement, the smaller movement, and so that's the treatment basis for both the LSVT Big and the LSVT Loud treatment protocols. And in these protocols, while one therapy is speech-based and the other therapy is based in occupational therapy and physical therapy, there's one treatment target for both of these treatments, and that's increasing amplitude. We're increasing movement across multiple motor systems. And so we are dual task training. We are training multiple motor systems at a time, such as in the speech example I gave earlier, better respiratory support, better vocal cord movement, better articulation, but it just had one treatment target of increasing amplitude, which in the speech world is increasing loudness. And so we're also within this treatment target of one focus, relearning a new internal cue, so how to get the patient to recognize that their soft voice is too small and that their small steps are not adequate, are not within normal limits. And so not breaking the systems down and practicing with one target, we're making changes across whole motor systems, both in movement and in speaking. And we also see that with these therapies, we can more easily collaborate across allied professionals. I work closely with my occupational therapists and physical therapists who are trained and certified in LSVT Big, and we can really collaborate and understand what the other is working on, so that when one person sees the patient and then the next therapist sees the patient, we know that they've been working on increased amplitude as a whole, and I know how to help them with that when I see the patient. So it really is a good collaborative impact that having one therapy focus really does allow for. Next slide, please. These protocols, so what's unique about LSVT Loud and LSVT Big? So next slide. So these programs are administered in an intensive manner to challenge the impaired system. These therapies are not at all passive. Patients are getting in there and they're getting a workout. They're working out their voice in LSVT Loud. They're working out their bodies in LSVT Big. Patients will feel a degree of fatigue at the end of a therapy session. Not pain or strain, but that good fatigue that comes from having a really good workout. And so we're really challenging a system that perhaps hasn't been challenged, hasn't been pushed, perhaps for years and years. And these techniques are specific to Parkinson's disease deficits. So the slowed movement, the smaller movement, that's what we're focusing in on by increasing a patient's amplitude of movement, amplitude of voice. And we also get in there in our time with our patients and address the sensory deficit. When I have a patient who feels that their quiet voice is normal and that a normal sounding voice feels to them as though they're shouting, I know that I have to spend a lot of energy on recalibrating their sensory system. So there's this kinesthetic awareness that is at a deficit with Parkinson's disease because they don't realize that they're moving smaller or that their voice is smaller and quieter. So that's a really big part that traditional therapies just did not hone in on. Another unique aspect of the LSVT programs is that they're supported by over 20 years of research, much of the funding coming from the National Institutes of Health, so that we could really establish treatment efficacy and show that this is a therapy that gets results and that works. Next slide. So for those of you not aware or who haven't gone through one of the LSVT programs, the delivery will always be with an LSVT Big physical or occupational therapist, or if you're doing LSVT Loud, it would be with an LSVT Loud certified speech therapist. Not all OT, PT, or speech therapists will do this therapy. It is additional training. It's an additional certification, so that's something that's unique. And all therapy sessions will be one-on-one. It's not group therapy. Patients may go to like a group situation after they've done the initial course of therapy for maintenance later down the road. But when they initially receive LSVT Big or LSVT Loud, it's one-on-one with the therapist. The time of practice, it's 4 consecutive days a week for 4 weeks, or 16 sessions in 1 month is another way to put that. The sessions last for an hour, and in addition to that hour of working out every day in therapy, patients also will do daily carryover assignments. So 30 days, that entire month that they're in the treatment course, they're doing carryover assignments, and they're also doing homework every single day. So next slide. So really an intensive program to be sure. The fundamentals of LSVT Big and LSVT Loud is that they are standardized and research-based. It is a very specific protocol, so the therapy that you would receive in Denver would be the same therapy you'd receive in Texas or Milwaukee or Kentucky, that you would be receiving the same protocol. The target is amplitude, increasing range of movement, making movement bigger, making the voice louder, so the target is amplitude. The mode will be intensive and high effort, as the previous slide detailed. It's a big workout for that whole month that you're in therapy, certainly with 4 days a week of treatment and daily carryover and homework tasks every day of that month. And then with the calibration, that's where we focus on generalizing. In a session, we can often get patients to use a louder voice or to move in a bigger way pretty early in therapy, sometimes even straight out of the gate in their very first therapy session. But the big barrier and why treatment was previously felt to not work is that it didn't generalize. So we address the sensory issue of tackling people who feel like they are moving big enough and talking loud enough when they're not. Getting the patient to recognize on the inside when they get soft in the voice or when they get small in their movement. And also addressing some of the neuropsychological changes that come along with Parkinson's disease. Next slide, please. So talking about calibration a little bit, how this can look in a therapy session is it's this mismatch between the online perception of the output and how others are perceiving it. So when I get a patient who is talking at a normal loudness, they will tell me, I feel like I'm shouting. Erica, who gets a patient to move in a normal amplitude with good movements, she'll have patients who can say, I can't move like this. People will think that I'm crazy. We have sort of a famous example that we all think of is a patient who felt like he was walking like the Pink Panther. And for those of you who are familiar with the Pink Panther, he had this very big exaggerated walk. And so a patient told a therapist that once, and when in fact, when they were moving, it was totally normal looking and didn't look absurd like the Pink Panther walk did. So those are examples of what we'll see and hear when there's this mismatch and that we have to address that with calibration. So pre-treatment, patients get in a vicious loop where at the bottom of your screen you'll see that there's this reduced amplitude of motor output, and as a result they produce slow, small movements or a softer voice. There's also this issue of self-perception and awareness where they don't recognize small movements or small voice. So they don't have the cue on the inside to move bigger or to talk louder, and that continues this cycle of scaling a reduced amplitude of movement or a reduced voice, and it becomes this really vicious cycle that you see here. However, next slide, when we get into therapy, what we focus in on first at the bottom of the slide is increasing the amplitude of motor output so that patients produce larger movements, louder voice, and then that will move into the therapist improving the patient's self-perception and awareness of amplitude that's required to produce a normal movement, normal voice, which by focusing on this improved self-perception, patients can then start recognizing from the inside that they are moving appropriately when they're thinking big, that they're talking at an appropriate loudness when they're thinking loud. So we're improving this self-cueing and their attention to action so that they habitually scale this bigger amplitude of movement and voice, and then we see this positive loop forming and perpetuating itself, which is wonderful. Next slide. So what I'm going to talk about specifically after as we've just finished up that overview of LSVT Loud and LSVT Big are changes in swallowing associated with Parkinson's disease. Next slide. We see that Parkinson's disease causes more rigidity of the lips, tongue, and jaw, just as it can cause rigidity in our limbs or in the trunk. We also see that there will be a delay in initiating a swallow. So food or liquid may be ready to go down, so to speak, but there's this delay in initiation, and that's because of the bradykinesia associated with Parkinson's. There's also overall weakness and reduced amplitude of movement in the lips and the tongue. And just as there is a sensory deficit with limb movement and with voice, there may also be a sensory deficit with swallowing as well, as we'll talk about on the next slide. These are two studies where it was actually found that patients who had no complaints of swallowing, if you ask them if they choke or if things go down the wrong tube, so to speak, there was actually patients who were identified to have food or liquid go into the airway or down the wrong tube, and they would not cough. Usually we have a strong cough response when something goes the wrong way. But for these patients who said, my swallowing is fine, They were actually aspirating food and liquid material into their lungs. In the second study, 13 of 20 Parkinson's patients who also denied problems with their swallow, their exams that were done in radiology revealed abnormalities in 8 of those 13. So in the majority of those patients, it was shown that they had abnormalities that they weren't feeling. So that's what makes us think that there's also a sensory issue. Next slide, please. So swallowing deficits in Parkinson's disease. It's been reported that as many as 95% of people with PD have a swallowing disorder. And on the next slide, we'll see what some of those disordered swallowing symptoms are. It can be impaired mastication or impaired chewing, reduced tongue strength. Our tongue is vital to how we form our food and how we swallow it. Decreased formation of the food or liquid that we are going to swallow. It's important to have it formed into a nice sort of ball or bolus. And we also see that there's decreased formation when it's transported, so that smaller movement. The tongue may rock back and forth more when they're trying to form their food and liquid. A tongue tremor. Piecemeal deglutition means swallowing what's in your mouth in small pieces at a time rather than one big swallow. It becomes several small swallows. A delayed pharyngeal response, meaning that your throat doesn't start the swallow until later, which can increase the likelihood that food or liquid will go into the airway. An impaired motility with residue left over in the throat. So when we swallow, we should have everything go down into the esophagus in one nice motion, but there will be problems in the throat muscles where folks will leave food and liquid material behind in the throat and it doesn't get to the esophagus. And these will translate into seeing food or liquid that penetrates into the upper airway where the vocal cords sit, and it can even be aspirated into the lungs. Next slide. So what impacts this have on the person who has a swallowing disorder can be quite meaningful, have quite a big impact. It may be difficult to take medication, such as pills. There may be an inability to maintain hydration and nutrition, and we all know how important those are to staying healthy. And when we have a swallowing disorder, we're more likely to develop pneumonia. And pneumonia can be sometimes deadly. So these are absolutely big impacts that having a disordered swallowing can affect us with. Next slide. So with this, we are looking at what are the effects of LSVT Loud on swallowing. These were kind of unexpected at first changes. When we got into developing LSVT Loud, we were looking at changing the voice. But then we found that there were some improvements with swallowing as well. We found that people were moving their food and liquid back faster from the mouth to the throat, which is a better coordinated swallow, a more normal coordinated swallow sequence. There was a decrease in how much food and liquid patients were leaving in their mouth after they swallow, so more of it was getting to the esophagus, as it should be. And there's also an increase in the oral and throat parts of the swallowing and how efficiently they were working. Next slide. So why did we see these changes following LSVT Loud, and why does it matter? So LSVT Loud, with this intensive exercise that works on amplitude of the throat, of the mouth, because that's where we also speak from, may activate neuromuscular control over the entire aerodigestive tract. So improving breath support when we're swallowing, improving the vocal cords response, and certainly the other muscles in the throat, and thus improving the swallowing. We also may be providing increased sensory stimulation. We're really tuning our patients into how they are moving and getting that internal cue so that we can drive long-term cross-system changes. The voice and swallowing both occur in the same part of the body, and so by changing the voice component, we may also be affecting the swallowing as well. And this was supported by PET scan data as well, which is a type of brain imaging. Next slide. And so with the daily tasks of LSVT Loud and with the hierarchy exercises, these are some of the tasks that are voice-focused that may impact the swallowing as well. Next slide. In the voice treatment, you'll see on the left side of your screen, by improving loudness, this may improve, on the column to your right, how well the vocal cords close. And the vocal cords are supposed to close when we swallow as well. So that's the effect that voice treatment may have on swallowing. Pitch range, we do target that in the voice treatment. And so by increasing a patient's voice pitch range, we may be also affecting laryngeal elevation. And laryngeal elevation on swallowing is important because that's what closes the little trap door in the throat that we need to close when we swallow. And also the voice treatment, it will improve the effort and coordination across the speech mechanism. And so because we're addressing respiratory, throat, vocal tract, and the mouth, these can all have an impact on swallowing as well. Next slide, please. So as we talk about many people with Parkinson's disease having a swallowing disorder, we wanted to share tonight some common treatment approaches for swallowing deficits in Parkinson's disease. And this is in no way to try to replace therapy, and nor are we saying that LSVT Loud will fix all swallowing issues. We've really only seen it so far affect the three mentioned previously. We are still studying this, and some of our data is yet to be published and analyzed. But we want to also give people more information on how to treat their swallowing disorder. So best practice, the best way to go, is really to see a speech-language pathologist and have therapy that's determined and supervised by them. Some of the techniques they may have you do would be modifying the size of the sip or bite that you're taking. It may be modifying what posture you're sitting in, so perhaps more upright, perhaps with a chin tuck. It really varies person to person. Some patients benefit from doing different maneuvers when they swallow, and this would be determined by the speech-language pathologist during a radiology exam where they actually watch you and your throat while you swallow. For some patients, altering their diet consistency is necessary. Using sensory stimulation such as very cold or very sour items to sort of stimulate the swallowing mechanism. Providing patients with exercises to strengthen their oral and throat parts of their swallow. And sometimes altering the feeding environment is necessary to reduce distractions and to make sure the patient is in the right posture. Next slide. With the exercises, muscle strengthening exercises, including LSVT Loud, may increase tongue strength and the range of motion in the elderly, and may also help people with Parkinson's disease. So this can be one of the therapies that helps. Most patients need additional therapies that just focus on the swallowing, but LSVT Loud can be a part of that solution. Next slide. So some general safe swallowing recommendations that I want to leave you with tonight that generally help most people with Parkinson's disease include sitting upright in a forward-facing position while eating, remaining upright 60 minutes post-meal times to make sure everything has had a chance to work its way out of the mouth and throat and the esophagus, eating and drinking at a slow pace, limiting distractions, not talking or while you're chewing or when you have food or liquid in your mouth, which is a good thing for everyone to do, but something a lot of us don't do. Frequently dry swallowing in between sips and bites. We talked about how often residue is left in the mouth or in the throat after someone swallows, and so taking just a little swallow of saliva can help clear that. Smaller bites and sips, avoiding drinking from straws because straws will shoot liquid back faster to the throat, and performing tongue sweeps around the teeth and in between the cheeks after a meal to help clear the food. And with that, we'll go to our summary slide, and then I'll hand it over to Erica. So swallowing issues are common for those with Parkinson's. LSVT Loud has preliminary data to support improvements in the oral phase of swallowing. So while this won't replace most traditional swallowing therapies, it can be a really good adjunct, a good addition to therapy. And so direct swallowing therapy may still be needed to address swallowing issues. And with that, it's important to consult with your speech-language clinician to determine your plan of care. And with that, I'd like to pass it over to Erica so that she can talk about activities of daily living.
Thank you, Heather. That was wonderful information. And now we'll move on to LSVT Big and how we can affect ADLs in daily life. So this first slide is just demonstrating what a typical treatment session would look like for LSVT Big. So on the left-hand side of your screen, you see a set of exercises, and then on the right-hand side of the screen is some functional activities that I'm going to get into more detail on. Next slide. So the first part of the session would consist of the maximal daily exercises. So your certified LSVT Big clinician would be trained at a certification and training workshop in regards to how to help teach you these exercises. And all of these exercises were carefully thought out. Becky Farley took a lot of time, she's a physical therapist, to analyze the movement needs in someone with Parkinson's disease. So all of these movements were specifically developed for the purpose of addressing specific component areas that are really important to the movement of someone with Parkinson's, and a lot of things that are lost as far as posture and extension of the limbs and the arms and the legs, and some stretching techniques. So they're all incorporated together here to help us gain some function back. Next slide. So the purpose of all of these exercises is really to learn the right amount of effort to use when we want to get normal movement to come out of the body. And as Heather was describing, we want to make sure that we, in the therapy, as therapists, teach how to gain that amplitude of movement to feel like that is normal again, to override that slowness or smallness of movement. And we're really trying to force the use of these muscles to improve and restore functional activity, which is really the end goal. We're trying to drive neuroplasticity, so trying to drive changes in the brain. We are also working to improve coordination, balance, strength, flexibility, as well as endurance. So all of these exercises are addressing not just the movements that you see, but really there's a lot of things going on behind the scenes when you use these exercises. Next slide. And really, with the use of these exercises, ideally, our end goal is to transfer the bigger movements or the effort that you feel with the movements into function. We want to make it meaningful to you so that you can function in everyday life with these movements. The next slide. So those exercises that you saw pictures of, and that's Jenny, one of our colleagues on the faculty. We have a homework helper DVD that has these exercises laid out for you. But really, in the end, yes, you can do these exercises really great with big effort, but we need to somehow link them to functional activity, because really the end goal of therapy is the functional activity that you want to perform in your daily life better, and we want to use these exercises really just as a tool to do that. Next slide. So really, this is a nice summary that it's all about function. We want you to be able to function better in your day-to-day life, and each therapist that is trained in this technique, is certified, they learn how to choose things that are going to be salient to you or important to you to make your function better. The goal of LSVT Big treatment is that people with Parkinson's disease will then use those automatic movements, these bigger movements, in everyday life just without even having to think about it, and that there's going to be long-term carryover of those large amplitude, big movements into everything that you enjoy doing. So how does LSVT Big really address using these bigger movements in ADLs? Next slide. So just taking a look back, one more slide forward. Perfect. LSVT Big treatment session. So going back to that first slide that we had up there, the left-hand side of your screen just shows those maximal daily exercises again laid out. Right side of the screen shows the functional piece of the treatment. So I'm just going to get into a little more detail on the functional aspect of the protocol for treatment. And so on this next slide, the functional component tasks are one of the first functional things we're going to have you work on. So we're going to pick 5 everyday tasks, which are simple one-step movements, and they're important to you. So they're something that we choose together. We personalize them to you. They never change throughout your 4 weeks. As Heather mentioned earlier, 4 times a week for 4 weeks, we use these same tasks, and we practice them repetitively, over 300 reps in 4 weeks. So some examples on the next slide as to what those might be. One-step tasks such as buttoning, zippering, opening a fridge, opening a medicine bottle, opening the cap off of a water bottle, sit to stand, which is always one that we use for everyone because that is a very common problem in Parkinson's disease, turning on and off a light, reaching up to a shelf, picking things off the floor. So very simple one-step tasks that we go back to the idea of effort that we're using in our maximal daily exercises, that we then transfer that to a very simple one-step component task such as these. And then there's another part of our functional portion of our protocol called the hierarchy. And these are complex tasks. So we come up with a larger task that have multi-step components to them. And again, it's important that it's something that you want to do better, that the patient is finding important, and that they're having some trouble with. And we're going to help them work through some of the issues that they're having with that and getting over some of those barriers. So we're going to use specific goals for each patient. Next slide. Some examples of hierarchy tasks that we might choose would be like a full dressing task, so getting ready in the morning to get out and go to your appointments or go to church, showering and bathing, preparing a whole meal. There's lots of components that go into that, and retrieving items and setting the table and doing the dishes, doing a whole laundry task, shopping, eating a meal. So a nice list of examples of larger tasks that we can then utilize in our treatment to help retrain the large amplitude movements that you're using during the exercises into actually something that's meaningful in your everyday life. Now on the next slide, we have a really great video we'd like to share with you tonight. And it is of a gentleman who went through LSVT Big, and it's going to show a LSVT Big treatment demonstration of how getting in and out of bed might have looked. And then after the 4 weeks, we re-videotaped this task, and you'll see the improvements.
You're ready.
Ready?
Yep.
Cool. Yeah, the immersion?
Yeah, the immersion.
When are you going to do it? In April? Yeah. You might have to. Okay. That's pretty good.
Mm-hmm. Yep. All right, now go ahead and get out of bed.
We practice that. Yeah, then I'll see it. Immersion is great. You know.
ahead.
Ready?
Yep.
All right.
Okay, excellent. So you can see how the difficulty of getting in and out of bed was a big struggle at the start of therapy, and we're able to really retrain use of effort and get those tasks to be more of ease in your day-to-day life, which is really a great thing about LSVT Big. We want to make it important to you. Some other things that are really great that we can take a look at are fine motor tasks, and we can look at a larger task such as getting in and out of bed, which requires the entire body to be moving and functioning together to help with that movement. And however, even with small tasks like zippering, buttoning, stirring things, brushing teeth, taking off caps, all of those kind of things, those movements are even small in people that have Parkinson's disease, and it's really because even those small movements are scaled down from what is normal. Those movements are coming out small and slow. And so this next video we'd like to share with you is a video of a gentleman named Bob. He is going to demonstrate his improvements with buttoning from when we were just had him in for a little bit of a demonstration on how LSVT Big was going to work. And you're going to see some really great things here.
Good, and I want you to just kind of notice as you're watching Bob do his buttons, it's a very slow, small kind of movement that he's using to try and get those buttons through the buttonhole.
Yes, we do struggle.
And this can be a very frustrating thing for a lot of people, Bob. You're not alone in that. Does the top button tend to be one of the hardest ones for you?
Yes.
Okay, okay. Good, you got it though. All right. Let's do it. Ready? 1, 2, 3. Go again.
Wow.
Really push it in hard. Nice.
About a third of the time.
You're right, you're right. Good job. Now go back in and close it like you're angry with it. Really push it in strong. Nice. How fast was that?
Even quicker.
Even quicker. You're right.
I haven't done a button that quick, and I don't know how long.
Good, good.
Okay, excellent. So you can really see that in a very short period of time, we're able to show Bob how to use bigger movements. First time he'd ever tried that, didn't even realize that he could make buttoning easier by just thinking about being big. And so it's really great that we can do it in a short time. However, as Heather mentioned in the earlier slides, we can get some changes very quickly in a short period of time. However, the body and the brain have not yet learned how to use those for the long run and for the long haul. So that's the whole reason for lots of repetition and for the dosage that Heather mentioned earlier, 4 times a week for 4 weeks. We need lots of repetition in order to get learned behaviors out of the body. And this is another example of a fine motor activity. This is one of my patients who wrote down 10 things they wanted to improve on when we started our 4 times a week for 4-week therapy protocol with LSVT Big. And I did not even specifically work on handwriting with this patient. And by the end, we had chosen other things that were more important at the time. And by the end, I had the patient rewrite these words and phrases down as far as what they were interested in working on, and without even cueing the fact to write bigger or to think about being big while writing, this is how the handwriting came out. So we see lots of generalized improvements in abilities with activities of daily living, and as Heather has been talking about this hour here, mentioning that, you know, really with LSVT Loud, you're looking at getting the potential of some swallowing improvements. And what's so great about LSVT Big is that many of the exercises that we do are not specifically teaching handwriting. And then we go into these functional components where we're then working on things that are important to you. But if we didn't even work on handwriting, we can still see some generalized improvement of amplitude on tasks, novel tasks, that we didn't even address. So it's very exciting to see that the body learns how to use this larger amplitude in unlearned and untrained tasks as well as trained tasks. Next slide. So just as a summary, LSVT Big is applicable to all stages of Parkinson's disease, which we didn't get into in depth this evening, but we have other webinars that address some of these issues in lower level or even higher level functioning people with Parkinson's disease. And so it can be customized. It's not a cookie cutter approach. We can customize it per patient, and we make it salient and important to each person. LSVT Big increases independence with ADLs, speed and quality and safety, balance, with all things that you want to do and enjoy in your life. And our focus is really to restore function, improve function, and maintain that for the long haul so that you can enjoy living.
Okay, thank you, Heather, and thank you, Erica, so much for a really informative webinar tonight. For all of you that are interested, please note that this webinar is being recorded and will be available on demand in about 48 hours after the conclusion of tonight's webinar. We will also be providing you a notes, the slide set of tonight's presentation in a PDF. If you're interested in attending other webinars, please note that the webinars are open to the public. If you go to our website, www.lsvtglobal.com, and click on Patient Resources, you can see a whole host of upcoming live webinars that you can join for free. And if you missed a webinar on a topic that you're interested in, those are in a different section called On-Demand Webinars. Our LSVT Big and LSVT Loud clinicians have their own webinars that are accessed through their clinician accounts. If you have frequently asked questions, we do have an FAQ page. Erica mentioned that we have LSVT Big and LSVT Loud homework helper DVDs. These are a great resource if you've gone through treatment already and need a little bit of boost or motivation to continue practicing on your own. The LSVT Loud Companion Home Edition is also an excellent piece of technology and a tool to help keep you motivated with your LSVT Loud practice at home, and can be used during the month of treatment as well. One of our future developments is that we're developing something called Loud for Life and Big for Life, which will be maintenance group classes led by ancillary health professionals, so that after you have completed your LSVT Loud and LSVT Big, you can go to a fun group class, stay motivated, and maintain the gains that you worked so hard for during the month of treatment. So without further ado, I want to thank you for joining us in tonight's webinar. I'm sorry that we ran a little bit long, but we are going to take about 5 minutes worth of questions right now. If you have questions after the webinar, or you don't feel comfortable submitting a question right now, you can always email us any question at info@lsvtglobal.com, which is shown right here. So with that, I'm going to open up for a few questions. All right. Right now I don't have any questions, and so I'm just going to wait for a few minutes. Okay, here is one question. How do I find an LSVT Big clinician? It's a great question. It's really quite easy. If you go to our website, lsvtglobal.com, you can click on a tab that says Find a Clinician, and you pick the type of clinician that you're looking for. LSVT Big in this case is what you asked for. and then you can type in your information. The easiest way to find a clinician in your area is to put your zip code in and then your search radius. It can go all the way up to 90 miles, I believe. Click on the box that says agree to search terms and conditions, and then all of the clinicians in that area will pop up with their contact information and other various information as well. Okay, it does not look like we have any further questions tonight. And so once again, I thank you for taking time out of your evening or out of your day to join us. We hope that this was a valuable webinar for you. And if you have further suggestions for future topics for webinar, please email us at info@lsvtglobal.com. Thank you so much.